So the group in Montreal, André Deneau, William Boubier-Souvigny, they looked at patients post-cardiac surgery and examined their portal veins. And they found that portal vein pulsatility was associated with adverse outcomes, particularly acute kidney injury, but also delirium and congestive encephalopathy following cardiac surgery. In the heart failure population, a lot of the early work was done looking at intrarenal venous Doppler. So actually looking at the kidney and looking at these tiny little interlobular vessels, because the artery and the vein, they run right together. And you can pulse wave Doppler these vessels that run together and look at flow abnormalities there. And then in acute kidney injury, we've looked at it using multiple different metrics, hepatic vein, portal vein, and intrarenal venous Doppler. But the problem is each of these in isolation have some limitations. There are certain conditions that over-exaggerate some Doppler markers, and actually there's other conditions that dampen some of the others. And so in 2020, Dr. Boubier-Souvigny and Dr. Deneau in Montreal, they said, how could we combine multiple different measurements into one kind of scoring system? And they took the inferior vena cava, hepatic vein, portal vein, and intrarenal venous Doppler, and they put it into something called the VExUS score that's become quite popular in the most recent years. And it's a score that ranges from 0 to 3, with scores of 2 or 3 representing kind of moderate to severe congestion. And this was derived and validated post-cardiac surgery. And what they found was that compared with central venous pressure and compared with any of the individual Doppler markers that by themselves, there was improved predictive accuracy to predict injury. Now, how did they choose the thresholds of portal vein pulsatility and the abnormalities? You got to start somewhere. So they just picked reasonable numbers and they looked at their data and picked reasonable numbers. And so VExUS is a new scoring system, but venous congestion ultrasound and venous congestion as a concept has been around for so long. And so actually in my practice, I don't use the VExUS score at all in our research or in kind of my assessment because it was derived in one population. We're studying a different population. And so we're interested in sepsis. Who's to say that the thresholds in sepsis are the same as in cardiac surgery? And so for our large international prospective study that we're just wrapping up right now, we're actually revalidating to look at for each of these markers, what is the threshold that causes congestion in this population? And do we actually need all these different components? Or maybe the portal vein is one vein to rule them all, so to speak, and will actually have the same predictive accuracy as a more comprehensive score and is much easier to do, for example, than the intrarenal venous Doppler.
So
And
are you allowed to
these
tell
are some
us
of the
what
questions that we
some of the
have
findings?
here.
It's too early, right? I'm assuming.
It's too early. We haven't had a chance to analyze the data, but interestingly, the parent randomized control trial Andromeda Shock 2 just finished recruiting today, 1,500
Amazing.
patients of septic shock phenotype resuscitation.
Okay, so we have this VExUS score, but it sounds like the takeaway is you can use the components at least as a baseline, and then kind of monitor them. And it's the IVC, the portal vein, hepatic vein, intrarenal vein. Yeah, so it's four components that you're looking at evaluating.
Yep.
And when you're coaching people to do this, are there any common misconceptions or mistakes they make when they're interpreting what they're seeing, or maybe they're putting too much stock into the IVC? And what are ways that we can get some discrepancies in terms of how to interpret it?
Great question. And to be entirely honest, there's a lot. So I'd say that the most important thing when you're starting to do venous Doppler is to recognize that this is an emerging field. There's increasing evidence, and there's a lot of layers of complexity to this. The first thing I see is that people rely a lot on the VExUS score. And for example, if the IVC is less than 2 centimeters on the VExUS score, you actually don't proceed with any of the Doppler markers.
Oh, interesting.
This is unfortunately a little bit challenging because we have a lot of data showing that patients with IVC smaller than 2 centimeters can have severe venous congestion. So unfortunately, stopping there is probably not a great idea. The next thing is trying to figure out the IVC and long axis, which is what is traditionally done in the VExUS score and what we're traditionally taught internal medicine and ICU POCUS. Well, it turns out that like any vein, the IVC is not actually round. And so, for example, if you go into the neck and you're putting in a central line, and if you see a very round structure that you're about to put a line into, stop, because there's a good chance that that's not the vein. We all know that the internal jugular is kind of this ellipsoid, partially collapsed structure. Well, the IVC is no different. It's a vein. It's ellipsoid. And so when you actually image it in long axis, you're assuming that the axis of this ellipsoid aligns perfectly with the long axis. But when you actually look at it in short axis, sometimes you see these bizarre IVCs that are like 4 centimeters in one diameter and like 2 millimeters in the other diameter. And if you catch that just right in long axis, you can falsely make it look really, really big or really, really small. And so we, for example, advocate for assessing IVC in short axis, because in short axis, you can actually kind of look at the sphericity or how round it is, because we know that as veins get more distended, they get more round. So perhaps that's actually a better metric to assess the IVC, for example, than long axis. And that's something that we're currently studying. Similarly, when we go to the hepatic vein, portal vein, and intrarenal vein, it can be hard to figure out what you're looking at, particularly the hepatic vein, where there's all these waveforms. There's up, there's down, there's E, S, V, D. And the researchers in us want to say, we'll just use ECG electrodes and you can correlate it. But that's not feasible. Nobody has ECG electrodes. We keep buying ECG electrodes for our center and they keep walking off to different parts of the hospital. So, and we do VExUS every day and we can't even keep track of them. And so what I advocate for this is just kind of thinking a little bit more simplistically about it. Blood should flow forward. On hepatic vein Doppler, that's flow below the baseline. The more and more flow you have above the baseline, regardless of whether it's ASVD, your kidney doesn't care, the more congested you are. And so we're interested in thinking about hepatic vein Doppler a little bit more kind of simplistically, just saying how much is backwards, how much is forward. Don't worry about which waveform is which, because the more that you have retrograde,
Right.
the worse congestion you probably have. I would say the portal vein is probably my favorite. I mean, if I was going to pick favorites here, you shouldn't pick favorites among your children, but if I were going to pick a favorite here with the ultrasound, it would definitely be the portal vein. If you go from the right upper quadrant, the main portal vein or the right portal vein comes right out towards you on the screen. You put Doppler on and you look at the pulsatility, which is just the maximum velocity minus the minimum velocity divided by the maximum velocity. Is repeatable. And interestingly, it seems to be the least affected by things like tricuspid regurgitation and other potential kind of confounders.
That's great.
And one of the reasons for that is when you actually think about the blood flow, it has to go from the right atrium into the IVC, into the hepatic vein, into the hepatic sinusoids, like through the liver parenchyma to make it into the portal vein. So if you're seeing pulsatility and reversal there, that can be a pretty good indicator of true kind of
So
congestion.
a good specific,
There is a
a
caveat,
specific one.
and it is specific except for the one caveat that it can also be totally normal. And so
Yeah,
if you
not
have
as
somebody,
sensitive.
exactly. So if you have a patient who's healthy and young and normal with like a totally collapsed IVC and a hyperdynamic circulation, they can also have portal vein pulsatility. So there's always confounders.
Right.
And then the last one is the intrarenal venous Doppler. And I really like the intrarenal venous Doppler. And the reason why is when you can get it, which is the biggest limitation, is that it's only kind of obtainable in about 90% of patients based on the literature. But if you can get it, it measures directly kind of renal congestion. And often when we're talking about congestion, we're talking about it in the setting of renal dysfunction, either a patient with AKI that we're trying to figure out, or a patient that we're diuresing and their creatinine's going up. And if you're measuring congestion at the kidney level and there's severe congestion, that's a pretty good indicator that there is that renal congestion is probably at play with whatever process is going on. And it's also able to be tracked over time very nicely because there's this concept of renal venous stasis index. And this might be getting a little bit into the weeds, but I think it's interesting. And so the idea is that normally veins should drain 100% of the cardiac cycle time. There should just be continuous venous drainage. But in settings of significant congestion, you start getting periods of interruption. And as those periods of interruption of venous flow get longer and longer and longer, your renal venous stasis index goes from 0, which is normal, up to 10% interruptions, 20%, 30%, all the way up to like 60 or 70%, where most of your cardiac cycle, there's no venous drainage. That's really bad. And going back to the compartment syndrome analogy, that lack of venous drainage leads to worsening congestion of the actual parenchyma, which swells within the capsule containing the kidney, causing worse venous drainage. And it's this kind of really negative feedback cycle, or actually really bad positive feedback cycle.
I'm sure there's nuances of when you look at the intrarenal venous Doppler, then you can get a better sense of the renal venous stasis. And what's enough to cause, say it's, 20%, 30%, or, 60%.
And you know what? That's a great question. So normal is 0.
Right.
You and I should be normal. But some patients their normal might not be zero.
Mm.
And so I always think of this with like EFs, for example. Like a normal EF is say above 65%. Yet you can have a patient with an EF of 30%, and that's just their baseline. So you have some patients that have baseline congestion. And no matter how hard you diurese them or how aggressively you kind of manage their heart failure, they just will always have congestion. That's not to say that it's normal, but it's just it's their baseline. And ideally, in an ideal world, it would be nice to fix that, but we can't
Yeah.
always. And actually, this brings into a really interesting use case. For example, patients with severe primary tricuspid regurgitation. And I have a friend and colleague, Eduardo Arguez, who actually has a primary tricuspid regurgitation clinic in Mexico City where he sees these patients. And interestingly, if you try to diurese people aggressively with severe primary tricuspid regurg, you can never improve their intrarenal venous Doppler unless by diuresing them, you've actually unmasked that this was not primary
Mm.
TR and this was secondary TR. They have severe renal congestion forever. Their portal vein will normalize or partially normalize, and you can use that to track kind of decongestion, but never their intrarenal venous Doppler. But when you send them for like tricuspid clip or tricuspid repair, and you fix the tricuspid regurg, their creatinine normalizes from a very elevated level back to kind of a normal level, which was previously unable to be accomplished by diuretics alone. So just because we couldn't fix their congestive renal injury with diuresis didn't mean that it wasn't having an impact on organ function.
Yeah, that's great. I think for me, this just really hammers home that every patient is different and different conditions will affect each of these four differently. So it is good to have a little bit more nuanced understanding of what affects what. So thank you for going through each and laying down what the high level nuances for what we should be um, caveating or thinking could be at play, not just venous congestion. To close this out, to inspire the person who is like, my gosh, how will I ever learn this? What do you have to say in terms of how often should one practice? How should one practice to get somewhat competent in an evolving area?
Yeah, that's a great question. I think the first thing I would say is that put aside ultrasound. I think the first thing is just recognizing that congestive organ injury is probably more prevalent than we realize. We've known about congestive injury for a really, really long time. But if you don't have a diagnostic tool to actually assess for something, you can't really study it. And so now that we have this tool, we're finding, oh my gosh, early in septic shock, a lot of patients have severe venous congestion. Wow, 70% of acute heart failure exacerbations have severe venous congestion on presentation. And the patients that improve their congestion seem to do way better than patients that don't improve their congestion. So I would say that hopefully this kind of excites us and to say that we have this kind of very prevalent phenotype of patients that have severe congestion and organ injury as a result of it. For example, we're studying right now in the intensive care unit the implications of venous congestion on delirium. And it turns out that venous congestion is associated with cerebral desaturations and worse, like
Mm.
delirium post cardiac surgery. And so maybe some of these patients that we have on medicine or in the intensive care unit that are severely delirious, and we're not too sure why, because they're not on any meds or metabolic glucose,
Yeah,
maybe the treatment for those patients is actually diuresis.
that's amazing.
And I just really want to encourage people to think about this kind of domain of organ injury, congestive organ injury, as something we're increasingly recognizing is probably more pathogenic in many of our populations than we previously realized. My second point is that if you're wanting to learn how to quantify venous congestion, if you're wanting to learn how to kind of really assess patient physiology on an individual basis, you need a tool that's repeatable, that's available, and that has some versatility. And the reason why I bring that up is I think POCUS is a great tool for that. And I think if I was starting kind of really trying to get into this, I wouldn't start with VExUS. VExUS is like level 2, level 3. Start with core acquisition of POCUS images, the heart, the lungs. There's so many really important findings that can really change your clinical management based on ultrasound. And I would start there. And then as that skill set develops, then we can start looking at venous congestion and learning how to do the Doppler patterns. And they're really not that hard. As part of one of our studies, we've actually taught 20 centers worldwide how to do VExUS, all remotely on webinars. And we do quality assurance on all the scans as part of the study. And there's excellent quality for these research scans. And so it definitely is feasible, even with just focused training. But all of these clinicians already knew how to use point of care ultrasound. And so I think that to me, point of care ultrasound, focusing on basic cardiac views, lung views, TVT assessments, intra-abdominal assessments, kind of for free fluid. Those are kind of core applications. And then you can easily build on that by assessing organ level Doppler after.